Is Hanh Mai. I'm a hematologist oncologist here at the Loyola University Medical Center in Maywood, Illinois, and I want to thank the organizers for the opportunity to discuss oncology practice during the COVID-19 pandemic, specifically focusing on our experience. These are my objectives for today. I will be discussing SARS-CoV-2 and the COVID-19 pandemic. Specifically, we'll be discussing COVID-19 and the cancer patient. The last point I'd like to discuss is ambulatory cancer care delivery during the COVID-19 pandemic, specifically focusing on the changes in the standard operations from our institution here in Illinois. The COVID-19 pandemic has transformed healthcare delivery around the world. This crisis has prompted physicians to make triage decisions that are essential to ensure optimal patient outcome, but also to minimize the risk to our healthcare workers. Cancer patients with SARS-CoV-2 infection often have excess mortality, especially in older patients and those with existing comorbidities. Severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2 for short, and the resulting illness, COVID-19, have emerged as a public health emergency and has been declared a pandemic by the World Health Organization. This newly identified zoonotic coronavirus is characterized by rapid human-to-human transmission. In December 2019, an outbreak of atypical pneumonia, known as COVID-19, was first identified in Wuhan, China. Now it has spread to involve more than 150 countries. COVID-19 has placed a major challenge on healthcare system, requiring adaptations and reorganizations of its structure in order to better care for our patients. As we all know, the disease course of infected individuals is phenotypically diverse, meaning some patients have no symptoms, some have mild symptoms, others have severe symptoms, resulting in respiratory failure, cytokine release syndrome, multi-organ failure, and death. Subgroups of patients with COVID identified to be at increased risk of morbidity and mortality include patients of older age, male sex, comorbidities such as having hypertension, COPD, diabetes, and cancer. Patients with cancer are more susceptible to infection, and that's because of their underlying malignancy, but also because of their ongoing anti-cancer therapy, all resulting in an immunosuppressive state. A recent small case series evaluating COVID-19 in the cancer patients as well as the non-cancer patients have found that those with cancer have worse outcomes. Liang et al. In Lancet Oncology from this year provided data from the Chinese National Registry. In this registry, they described about 1,500 patients. Of those, 18 had a history of cancer, which is about 1% compared to only 0.29% of the general population. Of the 18, 5 had lung cancer, 4 had chemo or surgery a month before, 14 of 18 in remission or under surveillance. These patients tended to be older, have a smoking history, and have more significant CT chest findings on admission. This is a graph from their study here, looking at the probability of severe events. And as you can see, patients without cancer here and patients with cancer. They concluded that patients with cancer were more likely to have severe events. By that, they mean ICU admission, requiring mechanical ventilation, or death. 7 of 18, so 39% with cancer versus only 8% without cancer, and that was statistically significant. This recent prospective cohort study from the UK was published actually just this month, highlighting again COVID-19 and the increased worse outcome with patients with cancer. So the all-cause case fatality rate in patients with cancer after having COVID was significantly associated with increasing age. Patients with hemolignancies having leukemia, lymphoma, myeloma had a more severe COVID-19 trajectory compared to patients with solid tumors. Leukemia patients showed a significantly increased case fatality rates. After adjusting for age and sex, they found that patients with heme malignancies who had recent chemo had an increased risk of death during COVID. So conclusion, patients with different tumor types have differing susceptibility to SARS-CoV-2 infection in COVID-19 phenotypes. Several factors could account for an elevated risk for acquiring SARS-CoV-2, and that includes, having need to go to a hospital frequently or having to visit clinic frequently, being immunosuppressed or immunocompromised from having cancer or from ongoing cancer treatment, advanced age, and having poor functional status. Where are we in terms of vaccine development? I can't help but put in this trial because it was published last week on October 14th, highlighting or reporting on safety and immunogenicity of 2 vaccine candidates. And this was published in the New England Journal of Medicine by Walsh et al. This was a placebo-controlled dose escalation phase 1 trial in the United States, looking at giving placebo versus one of these vaccine candidates to 2 cohorts, the healthy adults from 18 to 55 and those 65 to 85 years old. They looked at the primary outcome of safety and the secondary outcome of immunogenicity. And their conclusion was that this compound or candidate, the BNT162b2, was associated with a lower incidence and severity of systemic reactions in older adults. Therefore, this compound or candidate should be advanced to a phase 2-3 safety and efficacy evaluation. So stay tuned. We may be hearing more about the phase 2 and 3 data. Different susceptibilities to COVID-19 were observed between different age groups. We've seen that children showed a lower rate of infection and a milder disease course. One plausible explanation would be the difference in the quality and quantity of the immune performance that is shaped by the history of infection as well as vaccination, leading to this hypothesis. So immunity against prior influenza infection would at least in part foster immunity against SARS-CoV-2. We know that there's similarity in the quality of the immunity towards both viruses. Previous studies have shown cross-reactivity of immunity between influenza and coronavirus just due to their similarity in their structure. So the anti-flu immune response can induce a bystander immunity that is expected to augment immunity against other viruses like SARS-CoV-2. So it may be possible that those who have received prior flu vaccination may have a milder course of disease should they contract SARS-CoV-2. So given safety of the flu vaccine, it should be recommended during flu season to both healthcare workers and our cancer patients. So flu vaccine, please get your flu vaccine. Patients with cancer have worse outcomes, including higher mortality. Therefore, preventing exposure to COVID is key. The risk is compounded by similar factors as in the general population, so increasing age, comorbidities. It's uncertain how much of other factors, such as recent chemotherapy or ongoing chemotherapy or other therapy, adds to this risk. During a pandemic, it's very important to think about resource allocation. Okay, so strong leadership is necessary to ensure timely and proportionate implementation of plans to balance the risk of exposure, but also to protect the patients and the healthcare workers. It's important to implement strategies to minimize interruption of cancer treatment, especially those who are going for a curative intent. There should be education and to promote physical distancing as well as adherence to universal precautions. Elective surgeries and non-urgent outpatient clinics be deferred. Just to get a sense of the prevalence of COVID-19 cases, according to CNN tracking as of October 18, 2020, these are the number of cases worldwide. So you're looking at 39 or almost 40 million cases, and of that, in excess of 1 million deaths. And you can see right here on the right, the United States is actually leading. In the USA, there's about 8 million cases to date, and of that, about 220,000 deaths. You can see the top 5 states, and you can see that my state, Illinois, is in the top 5. So as of October 18th, there's been 4,245 new cases, along with 22 additional deaths. We've seen a trend in the increase in the rate of hospitalization. The rate of positive tests has been also increasing as well. So Illinois is potentially gearing for another peak, which is why it's very important to take this into consideration as we take care of our cancer patients. Balance is required between reducing transmission and also not jeopardizing cancer care. Clear communication and education about hand hygiene, infection control measures, social distancing is all important to consider. Clinic attendance should be limited to patient only. However, on a case-by-case basis, if patient one visitor to come along, then we should also consider that, again, case-by-case. Entry-exit points should be reduced with signs and personnel at these sites to facilitate communication and policy adherence. This is where we see it taking patients, our infusion center. Since the pandemic, we have implemented a strict screening protocol before patients arrive on site. Okay, so it's very important to have strict screening as well as readiness to identify and transfer potential cases safely without risking disease transmission. Standard operating procedure was developed at the onset of the pandemic, and these are modifications to our day-to-day workflow. These are some of the policies and procedures that were in place. So clinic areas were restricted to essential personnel only. That means no meeting or visits with outside vendors or representatives. Students were not permitted to be present in clinical areas. Trainees, such as resident physicians or hematology oncology fellows, should be present only if they're essential to providing medical care. Anybody with any sort of illness was encouraged to not come to work. So these are some of the appointments that we deferred for more than a month out. So our lung screening patients, our genetic risk assessment or survivorship, our Coleman Center appointments. And that's really for bra fitting for our breast cancer patients and wig fitting for our patients. These appointments were deferred. Each provider was encouraged to review in advance their clinic to see if some of these appointments can be converted to a telemedicine visit versus deferring. If an appointment is necessary, then a service representative or a nurse will call the patient one day before to screen the patients for these symptoms right here. And if they screen positive, so 2 out of that long list, then a nurse notifies the physician and a form will be completed. It's called the Patient Under Investigation form, which will be faxed to the infection control, and then the patient will be arranged to get tested at a designated center. If the patient needs to come in, when they come in, they will be mandated to wear a mask, and they will be directed to a screening station where their temperature is taken. A mask is provided if the patients don't wear a mask. If they need to wait either for an appointment or for something else, we have chairs set up 6 feet apart to protect these patients and minimize exposure. Lab draws are by appointments, and patients are encouraged to wait in their cars until their appointment time. Again, once they're on site, they must wear a mask. Our employees get screened every day using a thermal scanner. For positive patients, providers assess the need to start or continue anti-cancer therapy. Ideally, patient symptoms should have resolved and have 1 repeat negative COVID test. If patients absolutely require treatment, then they will be scheduled the latest appointment. to us after 4:30 p.m. in a designated room. Labs will be drawn in this room by personnel donned in full personal protective equipment, provider and nursing. If their treatment can be deferred after a quarantine period, which we specified, the 21 plus 3 days rule, so symptoms have resolved for at least 3 days and at least 21 days after COVID-19 symptom onset. Use telehealth as a bridge to clinical care if able. However, if not able and care is required during the 21-day period, then we maintain COVID-19 precautions. So patients must wear a face mask, and the provider or nursing staff will wear personal protective equipment. This is just to highlight some of the things that we put into place since COVID started, or the beginning of the pandemic. We converted routine follow-up or surveillance visits to telehealth. We pre-screen all of our patients a day before. We have no visitors allowed with limited exceptions on a case-by-case basis. We require face masks to be worn at our center. Anybody with COVID must wait 21 days after symptom onset or having one negative COVID test to resume care. COVID testing is mandated, required, but prior to start any chemo regimen, radiation treatment, or admission for chemotherapy. Tumor boards, some of which have gone virtual. We've decreased the use of non-chemotherapy infusions, for example, the IV iron patients. We've increased in the use of growth factor to decrease the reliance on blood products. We've delayed or deferred elective surgical procedures if timing is flexible, and we've delayed surveillance imaging in light of the pandemic. I'd like to end my presentation on discussing some of the points from the American Society of Clinical Oncology on rationing of care during pandemic. Okay, these are some of their principles, and oncologists should be involved in the policy development as it relates to cancer patients. Patients should not be denied consideration for use of scarce resources based solely on their cancer diagnosis. When needed, oncologists should provide additional information on the individual patient's diagnosis, status, prognosis, remaining cancer treatment apart from their COVID-19 diagnosis. The treating oncologist should not be the only one to decide about allocation of scarce resources. It should be a multidisciplinary approach where other physicians and RN practitioners, even non-clinicians, should be involved. And the last point is to emphasize advanced care planning with your patient in the clinic with good documentation. With that, I'd like to end my presentation, and I'd like to thank everyone's attention, and these are my resources. Thank you again.
Okay, we'll go to the second video, please.
Hi, my name is Amy Maros. I'm the manager for the Department of Radiation Oncology and interim executive director for the Oncology Service Line at Loyola University Medical Center in Maywood, Illinois. Today I'll be discussing oncology operations amid a global pandemic, our experience navigating COVID-19. Objectives for today primarily to discuss key aspects of our oncology COVID-19 action plan here at Loyola, specifically those restrictions we put in place, screening procedures and pre-treatment testing protocols, the care for COVID-19 positive patients, and ensuring a safe environment of care for both patients and colleagues. Second objective is to offer a couple of strategies for successful implementation, identifying the need for standardization of process across our large network, and also ensuring compliance of both patients and colleagues. So where to start? So in early March 2020, when our oncology leadership group determined that we have to sit down and put together a formal action plan to tackle the COVID-19 crisis, it seemed a bit like climbing a mountain. It was a fluid situation. There were a lot of unknowns, rapidly changing recommendations, and at that point in time, it was still pretty early in the game, so we hadn't yet received a formal procedure or guidelines from the institution, as they were also still working on that, and that was still in progress. The goal, however, was to put together a final SOP that was relevant to all of our oncology departments, which we have several, including our main hospital, Loyola University Medical Center, which houses our Cardinal Bernardin Cancer Center and Department of Radiation Oncology. We have 2 community hospitals, Gottlieb Memorial Hospital with its own cancer center, McNeil Hospital with its own cancer center, and 2 ambulatory offsites, Loyola Center for Cancer Care and Research at Palos Health South Campus, which has an infusion center and radiation oncology center, and Loyola Center for Health at Burr Ridge, which has non-oncology infusion, oncology infusion, and cancer center clinics. So those restrictions we initially put into place, our clinical areas were restricted to essential personnel only. We had no meetings, visitors, or outside vendors. Any individuals in training, including medical students, nursing students, etc., were not allowed in clinical areas. Even resident physicians were present only if essential to the provision of medical care, and for several months, resident physicians primarily worked remotely. This should go without saying, but any persons with any acute illness should not be present under any circumstance. Ironically, did face a barrier here. I think maybe some people can relate. In terms of colleague compliance, I think we're all kind of used to coming to work if we still feel well, but a little bit under the weather, maybe of cold, maybe of allergies, but you're not sure. So there definitely was a paradigm shift in trying to change people's minds and understanding that, if they're really feeling unwell at all, that they cannot come into work. All scheduled appointments were reviewed by the provider and converted to telemedicine or rescheduled when appropriate. Those routine screening, risk assessment, and survivorship appointments were all rescheduled to a later date. Barrier here regarding the telemedicine learning curve. So the pandemic really forced us to bring forward a more robust telemedicine program that we had not previously had here at Loyola. So with that, obviously comes many challenges in terms of technology. How do we train our staff and providers? How do we train our patients who are not accustomed to utilizing this type of technology for their care? But I think, generally speaking, looking back, organization really did a phenomenal job of rolling that out on a very quick timeline. And finally, there were restrictions in terms of visitors. All patients were limited to 1 healthy adult visitor greater than the age of 18 if the visitor is essential to care. With that, no visitors were allowed in infusion areas. We just felt like our infusion areas are particularly congested as it is. We didn't feel like there was a safe way to allow visitors into those spaces. We have updated these restrictions slightly. Those individuals in training are now allowed in clinical settings. However, they're limited to 1 clinical support person during busy clinics, especially our multidisciplinary clinics where we have many providers in those spaces. We've returned to quote-unquote normal pre-pandemic in-person clinic volume. So instead of physicians scrubbing schedules and either rescheduling and converting all appointments to telemedicine, we're instead making telemedicine available to those patients who ask and prefer it, or if the attending provider does determine that the patient should not be seen in person. As with many institutions, or most institutions, we rolled out some pretty significant screening initiatives. Starting first with colleagues, all colleagues must be screened daily prior to entry. So they have to screen negative to designated symptom questions and pass a daily temperature check. This process has gone through many iterations over the past 7 or 8 months. We initially started with all colleagues stopping at physical screening stations as we had an abundance of staff available due to decreased volume in clinics. However, as we've ramped back up, those staffing resources have dwindled significantly, and so as an organization, the decision was made to convert this process to an electronic screening process, which has been going pretty well. So we currently use the Certify Me screening application, which sends a notification daily via personal text message or email. If the colleague responds negative to the symptom questions, they can then proceed to work and undergo a temperature reading via an infrared kiosk. Goes without saying, but all colleagues must wear a mask at all times, even walking to and from their vehicle. Surprisingly, we still have some trouble with obtaining full colleague compliance with this, so we do have administrative leaders around at the change of shift to try to promote and encourage compliance with mask wearing at all times. Screening initiative for patients have several layers. The first step in the process is all patients who are scheduled for an in-person visit will undergo a prior day screening call. And how that works is our service representative will call the patient one day prior, ask screening symptom questions as listed below here. If a patient asks yes to any of the questions, then the service rep will notify the patient's nurse, who then consults the attending provider. Based on the provider's response, the nurse will follow up with the patient with instructions about their appointment. Is it determined that they should be referred for a COVID test? Will their appointment be converted to telemedicine? If that's able to do so, should the patient just be rescheduled? Or if it's determined that perhaps the patient has symptoms, but they're really consistent with side effects of treatment and they're not ill, it's okay for them to continue in person, then we can do that as well. Of course, if the patient answers no, the service rep will tell them they're okay to come in for their appointment the next day, but they will give them a heads up ahead of time of what the current visitor restrictions are and ask that the patient arrives wearing their own mask. This process regarding the prior day screening calls is only for those patients without consistent daily appointments such as radiation therapy or infusion visits. Those patients who are undergoing daily radiation therapy or infusion will undergo a prior day screening call before their first visit only. The idea being that our staff is consistently communicating with the patients as they're coming in each day to call if they have any change in symptoms or exposure history. So once patients come on site, all patients and visitors then must also undergo an on-site screening similar to colleagues, but in this case we still have our oncology clinical colleagues present at the screening table to ask the symptom questions. We feel like because our oncology patients do have complicated side effects if they are undergoing treatment that oftentimes overlap with the symptoms of COVID-19, we think it's appropriate to still have a clinical colleague there asking the questions to get more information versus just undergoing an electronic screening process. So they'll stop at the table and they'll be asked the same questions that they were over the phone. If a patient or visitor is not wearing a mask, they'll be provided one immediately. Again, all patients and visitors must answer the symptom questions and pass a temperature screening. If the patient fails the screening, they'll be placed in a designated exam room and their attending provider will be notified immediately to determine the next steps. Again, is it appropriate to send this person for testing or is it okay to continue with the visit? If they do have symptoms that are consistent with COVID-19, but the attending provider feels like they should still be seen in person, then that provider and all clinical support staff will be supported by wearing full PPE. If a visitor does fail a screening, however, they must return to the car. They will not be allowed to enter any of our cancer centers. Pre-treatment testing. On the inpatient level, all inpatients are now tested for COVID-19 upon admission. So by the time then they undergo treatment with us, if they are admitted, the understanding that they did receive a COVID test upon admission, so that result should be in their chart by the time we see them. On the outpatient setting, all outpatients require a PCR M2000 test prior to essentially starting any new course of treatment. So for radiation therapy, they'll receive that test prior to their CT simulation and initiation of a new course of radiation therapy. This is coordinated by our CT sim radiation therapists who handle the scheduling for those appointments, and it's typically done 3 days prior to the scheduled appointment. The barrier here is in the event that a patient does require urgent RT where we cannot, or it's felt that we cannot wait for the result of the COVID test prior to at least doing the CT simulation. We will proceed with the CT simulation, but then the patient must have the negative test prior to starting treatment. In terms of oral or IV infusion, patient must also undergo a test prior to initiating a first cycle of systemic anti-neoplastic therapy regimen. This is coordinated by the patient's clinic nurse, again, 3 days prior to the scheduled start of therapy. In the event that a patient is getting concurrent chemo and radiation therapy, we certainly don't want them to have more than one test done if we're starting treatment at the same time. So we've determined that that will be coordinated by the radiation therapy team, just so that way there's no overlap between the two groups. For those patients undergoing a hematologic transplant or CAR T therapy, they will also undergo a test, again coordinated by your transplant nurse 3 days prior to the scheduled transplant. We do face some common barriers here with requiring pre-treatment testing. A lot of patients, don't mind, they're on board, but we do get several patient refusals, or we have patients who have cited that they received a recent point of care test. Maybe they had a colonoscopy or some other test in the hospital where they received a point of care test. Unfortunately, we decided as a service line that we will only accept the PCR M2000 test result versus the point of care test result. So in these scenarios, patient must undergo a second test. Testing clearance. So if the test is negative, certainly cancer treatment can commence as scheduled. We do not repeat testing of asymptomatic individuals between fractions or rounds of chemotherapy. However, we encourage patients to self-isolate and take antivirus precautions during therapy. And if they do become symptomatic since the start of therapy, tending provider is notified immediately to initiate testing procedures and make decisions with how we're going to proceed with care. At the time of the initial pretreatment test, if it is positive, tending provider is immediately notified, and the patient by default will be retested 21 days post-symptom onset or the positive test, whichever occurred first. Ideally, we hold treatment until that test result is negative. However, there are scenarios in which the attending provider feels the patient still should proceed with therapy. So this is a decision that is made on a case-by-case basis, consulting the department chair, and if necessary, also infectious disease. So far, it's been a rare scenario, but if we do have to continue care for a patient who does have a positive COVID-19 diagnosis, we ensure that that patient is scheduled as the last appointment in the designated room or treatment area of the day. They're asked to wait in their car until we're ready for them to avoid any waiting in waiting rooms or unnecessary exposure to other individuals in the department. The total clinical staff is limited to only those who are necessary to deliver care. They don full PPE, including a surgical face mask, eyewear or shield, gloves, and gown. And the room and treatment area is cleaned thoroughly per our institution's current infectious disease guidelines. It's also important for us to ensure a safe environment of care for patients and colleagues. One of the main concerns that were cited early on is that we have very congested clinical areas. I'm sure a lot of you experience that as well, especially when we have multidisciplinary clinics where, again, we have many providers. We are an academic institution, so we have many layers of learners that also attend clinic. So we determined that for clinical areas, especially those busy clinics and multidisciplinary clinics, as I mentioned before, total clinical support staff is limited to one person per provider. To avoid congestion in non-clinical areas, we've spaced chairs 6 feet apart in all waiting areas. We have no visitors allowed in infusion areas, as I discussed before. Those are commonly congested areas. And all patients and visitors are asked to wait in their car until called for daily radiation therapy appointments. This is pretty much commonplace everywhere, but to provide protection to colleagues and patients, we've placed plexiglass dividers at all registration desks. All patient-facing colleagues must wear surgical-grade masks versus cloth masks as provided by the institution. And all clinical colleagues must wear eye protection in addition to a face mask during all patient encounters. So they don't have to wear the eyewear at all times, but if they are in the room with a patient, then the expectation is that they're wearing eye protection in addition to the mask. This is something they rolled out, I believe, anticipating concerns as we're approaching cold and flu season as well. So as mentioned early in the presentation, I'm going to offer a couple strategies for successful implementation. I think many of you can also speak to the fact that you have a large organization, maybe with multiple hospitals within your network. As I mentioned before, we're a large network with 3 hospitals and 2 ambulatory offsites. So it's essential to have standardization within this process among each site. We have providers and staff that rotate throughout various sites, oftentimes multiple times in a day. So consistency is really necessary for seamless transition and to ensure compliance. It's simply too difficult if you have staff and providers and patients who are being seen or practicing at multiple sites within the service line if each area has different protocols and processes. So we really tried our best to maintain standardization. So that way, even if you're moving from point A to point B, it's still the same screening processes in place. And that really ensures consistency and helps for successful implementation. Certainly between sites there will be different nuances. Even with our pre-treatment testing at our ambulatory off-sites, we send patients to a different location for testing than what we do at the other hospitals. Naturally that will exist, but as little inconsistency you can have, I think that really will ensure a successful implementation. Finally, to ensure a successful implementation, certainly you have to promote patient and colleague compliance. Regarding patient compliance, we found that communicating the efforts made to keep them safe is helpful. Again, during those prior day screening calls, we always start out the script with, in an effort to keep you safe, or we care about your safety and your health, and we're doing X, Y, and Z to ensure that. Also, minimize redundancy when possible. As I mentioned, our patients are getting phone calls prior to each appointment, and there are some days where a patient might have an appointment in radiation oncology, they might have an appointment in the lab, they might have an appointment in infusion. So we're still working on trying to coordinate among those groups to make sure that the patient doesn't get several phone calls in the same day to screen them for their appointments the next day. So that's definitely a work in progress. In some areas it might be difficult to minimize that redundancy, but at least if the patient feels like, their concerns in this regard are being voiced, then hopefully it'll in turn allow for more patient compliance because they won't get frustrated or annoyed with the process. In regards to colleague compliance, I think we all need to acknowledge here that change management is hard, even for a project that is not as daunting as rolling out these type of procedures. So in order to get around that, we really need to prioritize the dissemination of information. Here at Loyola, we had weekly and even multiple days a week ambulatory operations calls, especially in the beginning, so that way supply chain and our employee health colleagues and all those key stakeholders have had an opportunity to communicate changes on a daily or every other day basis, so that way then the managers can cascade that information down to the team, which I think is very helpful. We also have a daily management system in place here where we have various levels of huddles. So we have a tier 1 huddle that starts with colleagues and managers, and then multiple huddles that go all the way up. So the idea is at the tier 4 huddle, our presidents and vice presidents are cascading information down that eventually gets down to the staff. So I think if this communication is happening on a daily basis, again, because the information is changing so rapidly, that's really important to ensure that the information is getting to the folks at the front line. Another aspect here is to be aware of fatigue and to check in often. So I think that we've all kind of been through this where, towards the beginning, maybe back in March, we were a little bit more careful about certain things that we do. And then, 7-8 months later, it's easy to get fatigued with all these processes. And we need to acknowledge that we are putting a lot of extra steps on all of our staff members and extra items that they have to check off and do on a daily basis, whether for us it's the prior day calls or the screening, and it's easy to kind of slip out of that practice. So we need to be aware that fatigue does happen and to check in often with our colleagues to make sure that we're still following all those protocols that we've put in place. And finally, use your experts. I think some of our biggest allies have been our infectious disease colleagues and our employee health leaders here. When we had individual site concerns about the congestion in clinic, we've brought our employee health medical leadership out to do a walkthrough to see if they have any recommendations and to validate people's concerns. Similarly, if you have any colleagues, or we've had colleagues who are particularly anxious, about being here at work, again, bringing in employee health, medical leadership, infectious disease, nursing leadership, and experts to have conversations with the staff so that way their questions can be answered, because oftentimes, again, they're the experts and they can answer those questions that we cannot. So we need to make sure that our colleagues' voices are being heard and their concerns are being answered. And that's all I have for today. I did leave my contact information here, so feel free to reach out if you have any questions or you have any even areas where you think you can offer us any advice. We certainly would welcome that. I appreciate the time to speak with all of you today, and I hope you enjoy the rest of your meeting.